Hello, I am Leslie McGee with the Adult Protective Services Technical Assistance Resource Center, the APS TARC. Welcome to our presentation, APS Responses to Hoarding, being presented by Chris Dubble. This webinar explores Adult Protective Services best practices for identifying, assessing, and responding to hoarding situations among older adults and adults with disabilities. Participants will learn how to balance safety concerns with respect for autonomy, apply harm reduction strategies, and engage in collaborative, trauma-informed interventions. This session will also highlight risk concerns, engagement techniques, and the importance of person-centered planning. Next slide, please. As we get started, I want to cover just a few things. This webinar was created by the APS TARC, administered by WRMA Incorporated under contract number 140D0424F1178 from the U.S. Department of Health and Human Services, Administration for Community Living, Administration on Aging. The views expressed in this publication do not necessarily reflect the views or policies of the Administration for Community Living or the U.S. Department of Health and Human Services. The models and information provided during this webinar do not serve as official guidance to comply with any part of the APS final rule. All information provided is done so for informational purposes only. Next slide, please. This presentation is also being hosted by the APS TARC. Our mission is to enhance the effectiveness of APS programs by supporting our partners' use of data and analytics, applying research and evaluation to practice, encouraging the use of innovative practices and strategies, and providing APS programs with individualized technical assistance. Today's presentation is being recorded without a live audience. Should you have any questions after viewing this recording, please reach out to the APS TARC team using the contact information provided at the end of the presentation. We will be happy to discuss ways we can assist you, as well as any questions you have on this presentation. Next slide, please. At this time, I'm going to turn the discussion over to our presenter, Chris.
Thank you, Leslie, and thank you to the APS TARC for doing this webinar on such an essential topic for APS. Thank you, though, most of all, to all of you who are watching this for the work that you do every day and your dedication to continually learning and growing in this profession. In addition to the learning objectives that you see on the screen, I want to lay some groundwork for us that will help frame our time together. First, we can't possibly cover everything about this topic. Hoarding is a vast and layered topic. For APS, hoarding has mental health layers, social layers, risk layers, legal layers, and most certainly ethical layers as well. In one webinar, we can't touch on every scenario or challenge that may arise when addressing hoarding in APS, and that's okay. The goal is not to make you an expert in an hour. It's to build a shared understanding and explore ways that APS can assist in situations of hoarding and ultimately support the person in reducing harm. Second, this is not a clinical webinar. The training is not designed to turn APS professionals into therapists. We're not here to diagnose or prescribe treatment plans. In fact, I'm not a licensed clinician, but I have hung out with APS for quite some time. It's critical for all of us to understand that hoarding is a clinical condition, whether we're clinicians or not, because that shapes how we intervene. So while our role isn't clinical, we must recognize how to screen, when to refer, and how to work in collaboration with clinical professionals. Third, I want to acknowledge that APS is designed to be a short-term intervention, and hoarding is a long-term issue. And this is the crux of the challenge for APS in many of the situations that we face where someone is experiencing hoarding. Hoarding doesn't develop overnight and often can't be resolved in the timeframes applied to APS. You're often called in during a crisis, like an eviction, a fall, a hospitalization, and asked to resolve years of accumulation and trauma in a matter of weeks. That, quite frankly, isn't an realistic ask of you. But what you can do, and what we can do in APS, and what is important for us to do in APS, is to stabilize, build connections, reduce that immediate risk, and link that person to longer term support. That might mean just getting them to clear one path to the bathroom rather than tackling the whole home. It might mean a warm handoff to a hoarding informed therapist or support group. Small wins matter when it comes to working in these cases where people are experiencing hoarding, and they lay the groundwork for that long-term change. So for this webinar, I invite you to listen with curiosity. And remember, we're not here to fix, we're here to walk beside people who experience hoarding to support their safety. When we think about hoarding, one of the most infamous cases in the history is that of the Collier brothers. They lived in a large mansion in Harlem, but their hoarding behavior was hidden for years. It wasn't until they died in 1947 that the extent of the situation was revealed. Langley Collier had booby-trapped the house, setting up elaborate tunnels and piles of debris to keep out intruders. Tragically, one of his traps killed him. A massive pile of debris collapsed on him as he tried to bring food to his brother Homer, who had become paralyzed from rheumatism. When the authorities finally entered the house, they removed over 140 tons of debris. That is more than the weight of a Boeing 747. And in this image, you can see one of those tunnels. To make matters worse, their house had no working utilities. They had no heat, electricity, or running water. This case highlights how hoarding isn't simply about clutter. It's about isolation, hidden risks, and sometimes tragic consequences when needs and risks go unnoticed. Let's begin with a simple question. And I know this is recorded, but I still want you to think about this question. What is the first word that comes to your mind when I say hoarding? I'm going to give you a second. What'd you think of? When people answer that, when I do this in person, I often hear words like clutter, messy, overwhelmed, or even sometimes gross. And when APS professionals talk about it, I oftentimes hear words like intense, difficult, unsafe, unchangeable. Whatever response you had most likely comes from your personal and professional experiences with the issue of hoarding. Now that we've reflected on our first impressions, let's talk about what hoarding actually does look like. On the surface, we think of hoarding as rooms filled with items, narrow pathways, or stacks. You've all been in these situations. But hoarding isn't just about the things that we see. It's about the underlying emotional, psychological, and functional issues. At its base, hoarding looks like a person who collects and accumulates, has an urge to collect things. It's often described as an intense urge to collect things. But they also feel emotional distress when thinking about or going to discard those things. And third, and very importantly for us in APS, there is enough clutter that it interferes with their functioning and their basic life activities. So they accumulated a lot of stuff. They have emotional distress when trying to get rid of that stuff. And that stuff has accumulated so that it is affecting their activities of daily living, their basic life functioning. Another aspect of hoarding that is essential when we picture what hoarding is that it is often a lifelong issue. Anybody know what the average age that hoarding symptomology starts? It's actually 13 years old. Individuals have very early onset of hoarding symptomology, but tend to only either seek out services, or in our case, services coming to them in their 50s and 60s. So it's very important as we think about what hoarding is, we realize that it is a lifetime, a life course experience for people. Before I move on, I want to just touch on two areas that we're not going to dive deep into in relationship to hoarding. The first is animal hoarding. Animal hoarding is certainly part of what you experience in APS, and it's a very important part of what you experience. And a lot of what we talk about today can be applied to situations of animal hoarding, but there are enough distinctions between the hoarding of clutter and the hoarding of animals that we can't fully go into that area. The second area that we can't dive into in the interest of time too far is your physical safety. But these situations, based upon their environmental conditions, based upon how that person presents, can pose a safety risk. Those of you who have ever heard me do a safety training, you know my saying, when in doubt, get out. That applies to whatever type of case that you're in and applies to hoarding situations as well. So if you're in a home where there are conditions that you are concerned about your safety, I encourage you to leave that situation and talk with your supervisor about how you can approach that case in a way that is safe to you. What we are going to do today is we're going to approach or look at 5 approaches for addressing hoarding in APS. First is do no harm. Do no harm reminds us to preserve safety and well-being when we're working with people experiencing hoarding. The second is screening as a mental health issue. This ensures that we address the root causes, not just the clutter. Third is finding the goals that the person wants to set, which builds motivation and collaboration, allowing us to be truly person-directed. The fourth is to accurately assess risk, which helps us prioritize safety without overreacting. And the fifth area we're going to cover is planning for the long term, which helps us to respect the chronic nature of hoarding and supports meaningful, sustainable progress. First is do no harm. One of the most important ethical principles guiding our work in APS is do no harm. It's simple to say, but deeply complex in practice, especially in situations of hoarding. Doing no harm reminds us that every decision we make, every home visit, every recommendation, every referral should be weighed not just for its instant impact, but for its impact on the person we're serving over the long term. We don't judge it also based upon intent. We judge it based upon how it affects that person. We may be called in during moments, and often are, right? You're called in during moments of visible crisis. There are blocked exits. There's an overwhelmed landlord calling you or a concerned neighbor. But if we jump into action without care, we can lead to unintended harm. Research actually shows that forced interventions like clean outs without consent often result in trauma, relationship breakdown, and rapid reaccumulation. In fact, one study found that over 80% of people who experienced an involuntary cleanout relapsed within a year. That's not just ineffective, it's harmful to the person. We must also, when talking about hoarding in our approach, talk about stigma. People who hoard are often judged harshly, not just by neighbors or family, but by service providers too. I know some of you have experienced that in talking with allied professionals. Words like disgusting, gross, or even hoarder carry powerful emotional weight. And that stigma can create silence. Studies have shown that people with hoarding disorder are less likely to seek help and more likely to disengage from services if they feel judged or disrespected. In one national study, nearly 80% of individuals with hoarding disorder reported avoiding visitors due to embarrassment. Another study found that the fear of public exposure and shame was the leading reason people refused assistance and support. So when we enter someone's home, our mindset matters. We're not just there assessing for APS. We are navigating someone's identity, their history, and emotional survival system. We must remember that we are guests in someone else's home, someone else's living space. Even if that home feels unsafe or unsanitary by our own standards, it remains that person's private environment and is often a source of identity and history. Entering with humility and sensitivity helps us avoid unintended harm. One study found this really fascinating, found that individuals with hoarding disorder report higher rates of traumatic experiences, including feelings of violation when their home is entered or altered without consent. The study went on to say that older adults with hoarding disorder describe professional home visits, professionals, that's us, as invasive or disrespectful. Now, let me clarify, that study wasn't about APS, but it was about folks who are going there most likely with good intent, and that's still being received as invasive or disrespectful. That leads us to the point about harmful interventions can damage trust. If someone experiences a forced action, such as a surprise clean out or a threat of removal, without being part of the process, the impact can be long lasting. They may shut down, they may avoid services, or stop answering the door entirely. Many of you have been there. When trust is broken in hoarding cases, service engagement often drops drastically. In some communities, research has shown that up to 60% of individuals disengage after a traumatic intervention. And when this happens, if this happens, we may never get another chance. So, what are some tips for doing no harm? Number one is don't lead with cleaning or cleaning services. Don't lead with cleaning. Don't lead with cleaning. Don't lead with cleaning. And just in case you missed the first 4 or 5, don't lead with cleaning or cleaning services. It's tempting, and I've been there with you. It's tempting to want to jump straight into action. You're walking into unsafe environments or environments that you perceive as unsafe with piles of paper near the stove, pest infestations, cockroaches, all those yucky things we're seeing. And it's natural to think, because in our head it's yucky, it's our head it's unsafe, that we need to get this cleaned up right now. However, that urge to fix can do more damage than good. Our interventions can damage the person's trust in APS and other support systems. Instead of having that reflex reaction to fix, we want to try to step back, particularly in that initial visit, particularly in those early stages of our case, and prioritize the relationship. As we talked about, people experiencing hoarding may already feel judged, isolated, or afraid of being forced out of their homes. If we enter with urgency but no connection, we risk being seen as just another threat. Let me repeat that. If we enter with urgency but no connection, we risk being seen as just another threat. One study found that individuals who feel heard, respected, and engaged in decision making, heard, respected, and engaged in decision making, are significantly more likely to reduce safety risks voluntarily. Building readiness, though, doesn't mean waiting forever to intervene. We don't have that luxury in APS. But it does mean asking things like, what's one small step you'd feel okay taking? That may be just clearing a path to the bathroom or removing expired food from the refrigerator. When the person, and we'll talk more about this, sets the pace, change becomes more long-lasting. The next tip centers on the fact that hoarding is rarely just about the stuff. One study found that up to 70% of individuals with hoarding disorder report at least one traumatic life event. Another found that people with hoarding are significantly more likely to meet criteria for PTSD than the general population. This means that even small interventions, like suggesting they discard something, can trigger a trauma response. As APS professionals, we need to use a trauma-informed approach in all cases. And I think we do that very well for physical abuse, sexual abuse, even some forms of caregiver neglect. But we also want to be aware of using that same approach in cases where someone is experiencing self-neglect, particularly hoarding. We also want to include the person in safety planning and harm reduction. And we don't just want to do this because it's best practice. We want to do it because it's evidence-based. Studies show that over 3/4, 3 out of 4 individuals with hoarding disorder resist outside intervention unless they're involved in the planning process. When people are invited to participate in identifying their risks and setting their own goals, engagement and follow through significantly improve. Just think about all of us, right? Do we like when people tell us what to do? Of course not. But when people engage with us and talk through what we're going through and help us set those steps, we're much more likely to follow through. Same applies when we're interacting with people who are experiencing hoarding. Empowering individuals creates that buy-in. Instead of pushing for those big changes, we can help them take ownership of small but meaningful safety steps. That, again, might mean just clearing a walkway to the bathroom or to their front step or their front door. Getting them to fix a broken outlet, or reducing the amount of trash that you're seeing all over around the trash can. These small actions can reduce harm while again empowering them by respecting their autonomy and their pace of change. It is, of course, crucial, and I can't emphasize this enough, that we coordinate with multidisciplinary supports. A coordinated multidisciplinary approach brings in the right support at the right time. Might be housing, might be mental health, might be fire safety, medical, legal, whatever it is. But it does need to be strategic so that it is not overwhelming to that individual. Studies on collaborative case management show that coordinated care leads to higher client satisfaction, lower rates of relapse, and more sustainable outcome in situations of hoarding. And for us in APS, for you in APS, this approach also helps distribute some of the responsibility, and as we'll talk about at the end, the emotional weight of these cases. High-risk hoarding cases can weigh heavily on APS professionals. They can elevate our stress and perhaps even our burnout, especially if we are working in isolation or without a clear approach and structure. Working with others gives us partners to not only address the issue, but support us as well. The next area is screened as a mental health issue. In your job, you're walking into homes with overwhelming amounts of clutter at times. Your senses are being overloaded. However, what you are walking into is more than just the clutter. It's a behavioral health crisis, one that requires more than just dealing with the stuff, but rather dealing at a deeper level. That is why it is so important to understand hoarding as a clinical diagnosis. Hoarding disorder is recognized in the DSM-5 TR as a standalone mental health condition. It's not a symptom of another disorder like OCD. It's its own diagnosis. And research estimates that about 2 to 6% of the general population meet the criteria for hoarding disorder. And prevalence actually increases with age. Among older adults, hoarding is often more severe and linked to cognitive impairment, anxiety, and depression. Identifying hoarding early as a behavioral health issue, a mental health issue, can help us in APS tailor our response. It shifts that conversation from why won't they clean up? Why won't they accept services? To what's making this so hard for them? What's making it hard for them to accept the services that I'm offering? Based upon this perspective, we can understand that the behavior is driven by something deeper. Simply removing the items won't address the compulsions, the beliefs about saving, or the emotional regulation challenges that underlie hoarding. When we look at the DSM, we see that there are a set of criteria to diagnose somebody as having a hoarding disorder. Now, you can see what's on the screen. Many of you are already familiar with this, but I have to say, this is the point when I do this training, particularly in person, that let me just tell you this story. I had one time where I'm like mid-sentence and somebody just yells out, "I may be hoarding shoes." They had self-diagnosed as hoarding shoes. Here is a very small part of my shoe collection. I love shoes. And I very purposefully only showed you one rack because I'm not sure how willing I am on a national webinar to reveal that my potentially unhealthy obsession with shoes. But as I told the person that interrupted, and maybe some of you are thinking about collections and things that you have, that you maybe have a little bit more than you need. That is not the defining factor for hoarding. The criteria that I want us to pay most attention to today, not just to relieve ourselves of self-diagnosis, but most importantly for our perspective from an APS standpoint. Because remember, we're not clinicians, we're not therapists, we're not doing the diagnosing, but it's number 4. Number 4, which is that the hoarding causes distress or impairment in social, occupational, or other important areas of functioning. When it comes to APS screening, this is what we do, right? This is what all of you do. This is the criteria that helps us connect what we do in our general assessment and what may be going on clinically for that person. We're asking questions. You're asking questions of, are you able to sleep in your bed? Can you safely leave the home in an emergency? Has this caused tension with family, landlords, or neighbors? The answers to those questions often reveal where risk and the need for additional clinical support become apparent. So when we recognize that this is more than just a lot of clutter or just having a lot of items or an obsession with certain things, when we recognize hoarding as a mental health issue, we also take a major step in reducing stigma. We talked about this. Too often, people who are hoarding, who are experiencing hoarding, are labeled as lazy, dirty, irresponsible, or even worse. These assumptions are only going to increase shame, reinforce that isolation, and push people further away from help. But when we as APS professionals use mental health informed language and framing, like difficulty discarding instead of refusing to clean up, think about that change. Difficulty discarding instead of refusing to clean. We show an understanding of the experience of that person. Screening hoarding as a mental health issue helps us uncover those root causes. Is there a trauma history? Is there executive functioning impairment? Is there a co-occurring anxiety or depression? When we can identify these factors early, we can better connect individuals to services that support their needs, the change that they need over time, as opposed to just the immediate. Finally, when we frame hoarding as a clinical issue, we're better positioned to collaborate across systems. It gives us a common language with particularly mental health providers, but even housing staff and medical teams and code enforcement. I found that when I was doing the research for the webinar, I found this one study that I thought was really interesting. It found that in multidisciplinary hoarding teams, cases where a mental health diagnosis was clearly identified had a higher follow-through rate and more effective cross-agency coordination. I speculate that's because when a diagnosis is acknowledged, we can align around certain treatment goals instead of focusing on just the containment or the compliance aspects of the situation. For you in APS, this is essential because you're often that bridge between systems. In that multidisciplinary approach, you're oftentimes the connection between the different systems. And mental health framing helps you and everyone else on the team have that shared common perspective. Some tips for screening hoarding as a mental health issue. Start with what you can see. Don't overcomplicate some of this. You don't need to have a diagnostic tool. Use your eyes and your training. It's what you're good at. When entering a home, look for those blocked exits, narrow walkways, excessive accumulation, particularly above the knees, or rooms that cannot be used for their intended purpose. For example, if the bed is buried and the person sleeps in a chair, or the kitchen can't be used because the stove is covered, these are red flags. Look at outlets. Look at exits. Look at those things. Use your eyes. Sometimes use your nose. These things aren't just safety issues. They are functional impairments that might be tied directly to the DSM criteria for hoarding disorder. If living areas are so cluttered that they cannot be used as intended, you have grounds to explore further. This focus on functionality helps us distinguish between cluttered but livable homes and those where health and safety are clearly compromised. Equally important is what we can't see, but what we can sense. Because remember, part of hoarding is that emotional distress when I think about or I go to get rid of something. So, how does the person react when you start talking about their belongings? Do they become anxious, withdrawn? Do they become defensive? Do they express strong emotional attachments to things that seemingly appear non essential? This emotional response is key. People with hoarding disorder often experience high levels of distress when discussing discarding possessions, even items that others would consider non essential or even trash. They may describe these things as part of them or fear that letting go of an item might bring bad luck or regret. If someone appears emotionally overwhelmed when you bring up safety improvements or cleanup, that is a signal to pause, remember mental health components of this, and shift, at least at that moment, from what you're doing to a supportive approach. Also, we want to include collaterals as much as possible. A neighbor might have a lot of information about how the house looks, because all of you on this webinar know there are times you're not getting in that house. So you're reliant on information from other people. Meals on Wheels driver may share that they can't take the items inside. A family member might mention that the hoarding began after a traumatic loss. This information is all valuable. According to the research, many individuals who are experiencing hoarding lack insight into the severity of their condition and minimize the impact or even deny that a problem exists. That's why outside observations, these collateral contacts, can be so valuable. Obviously, you need to do it within your rules of confidentiality and your policies around interviewing collaterals. But where you're able to, this information can be very important to your assessment. We also need to know when something is outside of our lane. If the person's behavior is interfering with a daily functioning, for example, they can't bathe, sleep, cook, those types of things, it's important to very quickly get additional help. Maybe that's a clinician, maybe that's a nurse, maybe that's geriatric care managers. They can all play a role. So we need to know when to refer outside of our role in APS. The next concept is to find their goals. This isn't just a philosophical concept, it's a very practical one. When you, as an APS professional, anchor safety planning and what matters to the person, rather than what we think should happen, you're going to see greater willingness to engage and act. For example, if someone says, hey, I just want to keep living here, or I want to see my grandkids again, those personal goals are starting points for helping you to have the conversation about what they need to do to accomplish those goals. The research backs this up. One study showed that people with hoarding disorder were significantly more likely to reduce clutter in areas tied to goals that they identified, such as being able to cook again or just have visitors. When they identified those goals, as opposed to those goals being externally imposed on them, they were much more likely to follow through. Another benefit is that it allows us to build internal motivation and insight for that person. The process itself encourages that person to have some introspection. If we just give the service or offer the services or give the answers, we're not encouraging them to think about their own situation. Research suggests that individuals who develop insight into their behaviors are much more likely to make meaningful changes that extend beyond the symptom management of their hoarding. If our goal, let's say, is, or their goal is to be able to cook again, we might say something to them like, well, I understand that you would like to use your stove again safely. What's getting in that way? Or we could say something like, how would you feel if we helped you be able to cook on that stove again? Using their goal as the focus point and the center point is key because it, again, that process helps them to introspect, helps them to self-reflect about what their goals are and how to get there. This type of approach also helps to reduce reluctance. When people feel heard when they are setting their own goals, they're much more likely to engage. One of my favorite cases I wasn't part of it. It was just brilliant work by one of your APS colleagues. They went out and it was a 72-year-old man who was refusing to part with newspapers that he had piled throughout his home. This worker, who was brilliant, asked what mattered most to him. And his answer was, I wanted my granddaughter to be able to come here for pictures when she graduates. That worker used that goal to help him get rid of just some area in kind of the entryway to the house. And 2 weeks later, when the granddaughter graduated, she was able to come and stand there for pictures. This gentleman then allowed that worker to continue to work and do more. It was so beautiful. It was so perfect of how that worker said, okay, like that's not a typical service plan in APS to say, I'm going to help this person clean out enough so that they can take pictures at graduation. But this worker was brilliant in thinking through, if I can help with this, maybe he will let me help with more. And in this case, that's exactly what happens. We've talked about a lot of this, but harm reduction absolutely helps people focus on their goals. Harm reduction in small pieces. So not thinking in how do we get rid of all of the risk, which is our temptation in APS. That's how I grew up in the world of APS. Eliminate risk or reduce risk, right? And we tend to think of it as a bigger thing. but thinking through what are those very practical, bite-size, if you will, steps that someone can take that may not eliminate all of the risk, but will reduce some of that potential of harm. For example, just helping someone move clutter away from a heater can immediately improve safety without overwhelming that person or threatening their sense of control. This approach of finding their goals and being person directed also just aligns with the ethics of APS. Autonomy, always using least restrictive approaches, respecting that person's right to make choices while helping them understand the consequences and collaborating with them to build those safer environments shows that respect for their autonomy, their right to make their own decisions. And a key part to autonomy is the right to experience the consequences of those actions. We respect autonomy when we help to find their goals and then prioritize their goals. It also helps us to be least restrictive in our interventions because they are directing what they want. And I'm not implying that there aren't times where we have to do something different legally or because of our policy. But it shouldn't, even if those interventions have to occur, it should never stop us from prioritizing what they have set as their goals. Tips for finding their goals is always explore their values and motivations, just like that worker did with the person who just wanted his granddaughter to be able to take pictures. What are their values? What are their motivations? Break that process, as we just talked about, into those small steps. How can we help that person set goals that are realistic, specific, and manageable? It's interesting, and this is not just from the research on hoarding, but just human behavior. When we can accomplish something successfully, it empowers us to do more. And in situations where someone is experiencing hoarding, research has shown that even modest progress can build confidence and reduce shame. Not only build confidence, but reduce shame, especially when they are living every day with their hoarding disorder. Next, we want to learn about motivational interviewing. Or learn some of the techniques about MI. Some of you know and have had training on MI in the past. MI approaches improve engagement with people with hoarding disorder and reduce avoidance behaviors in up to 60% of situations where someone is experiencing hoarding. Up to 60% of those situations, MI has been shown to be beneficial. So learn about MI, learn about the techniques that you can apply. Reassess and revise their goals frequently. Whoops. We want to take, and I know you all do all the time, right? But when it comes to situations of hoarding disorder, we absolutely want to take that reassessment process extremely seriously. Because what may have worked when we initially did or what we thought was going to work when we initially did the service plan, when we go to reassess, may not be working as well. We need to be open to reassessing and revising those goals frequently. And the reassessment that you do as part of your work in APS gives the opportunity to do that. We want to take in situations of hoarding reassessment very, very seriously. In the interest of time, I'm going to move, but of course we want to avoid imposing our own priorities. Again, letting them direct their goals. We have to, in these situations, accurately assess for risk. When we accurately assess for risk, we can prioritize safety without overreacting. There was a 2020 APS review that found that less than 1/3 of hoarding cases required urgent intervention. Yet over 60% received emergency level response due to misjudged severity. Structured risk screening ensures that we match our response to the actual level of danger and risk that somebody is experiencing. When we misjudge that level of risk, it can lead to outcomes that do more harm than good. As we've discussed, things like forced cleanouts are often traumatizing and ineffective. Many individuals will quickly reaccumulate possessions, and their trust in service systems just deeply damaged, if not destroyed. One review found that forced interventions led to increased distress in up to 70% of the cases, and in some cases, activated a crisis level response, including hospitalization or homelessness. If it's not documented, it's not done, right? We've all heard that a million times. And that very much applies to our situations, and applies to APS in everything, but very much applies to situations where someone is experiencing hoarding. We need to document at very high quality levels. We need to document based upon facts because it is what is going to be our justification about what that risk is and the actions we took based upon that risk. Finally, a clear risk profile improves collaboration with other professionals. It allows, just like we talked about with understanding it as a mental health diagnosis, having a clear sense of the risk allows us to know who to go to for support with that risk, and also how to explain it to that service provider in a way that is going to get the response that we need to address that risk. For example, if we distinguish between a blocked bathroom and if we just say it's a blocked bathroom versus a complete inability to exit the home, that's going to change how some service providers respond or how quickly they respond to us. So we want to have that sense of an accurate depiction of that risk. Here are some tips to accurately assess risk. I'm sure Leslie is going, Chris, we're almost out of time. I know, Leslie, I'm getting there. Even though it's recorded, I'm still on a time crunch. But here are some tips to accurately assess risk. The one I want to talk about a little bit is to use structured tools or checklists. I'll show you one example. It's the clutter image rating scale. And that clutter image rating scale is just an example. There are other things that you can do. You can have checklists. Many of your agencies have checklists that give you a way to objectively apply a standard to the things that you're seeing. Because when any of us are in this situation, particularly number 9 that you're seeing here, there's a degree that our own senses are potentially being overwhelmed to the point where we're not going to be the most objective. So having tools that can support our accurate risk assessment are absolutely critical. Again, I'm going to hit it one more time. Documentation, documentation, documentation. Make sure that you are using both as objective language as you can, like you see on the screen, kitchen stove obstructed by stacked papers, as well as descriptive as you can. Describing the height of things, the height of newspapers. Newspapers seem to be stacked higher than 3 feet tall. Having that level of description, again, is going to support your risk assessment as well as support the actions that you took. The last one that we want to talk about is planning for the long term. I think we've made the point throughout several of these that this is a chronic condition. Remember, average age of symptomology starting at 13. This is a lifetime of someone experiencing their condition. And so we're not going to be able to fix it immediately. So it's incredibly important that we think about it not as this one-time crisis that oftentimes it's being presented to us as, right? The reporter is like, you got to do something and you got to do it now. But rather thinking through of it, okay, yeah, I get it that that report is necessitating me going out. But what's the longer term approach to this? Knowing that quick fixes oftentimes backfire and that behavioral change is going to take time. Part of planning for the long term is coordinating with other services. I talked about some of the evidence that supports that when we have a good care plan with other services, it's going to dramatically increase the probability that we can have success in reducing some of that risk along with that person. Very importantly here is that a long-term outlook approach can reduce frustration and burnout from these situations. Remember one of the principles that I said at the very beginning we were going to ground ourselves in? And that is that APS is a short-term intervention or designed to be a relatively short-term intervention, but hoarding is a long-term issue. I have talked with a lot of you throughout the country, and I hear it a lot. The emotional feelings of having to close a case, having limited services to put in place, or having someone to tell you they don't want services and you're not sure about their safety. You're not sure about the risk. It takes a toll. And we never want to minimize that toll that it takes on our APS professionals, on your colleagues, maybe on you. Reframing this as a long-term issue, both as a worker, but I'm also going to pick on my directors and supervisors as well. Making sure we don't get caught in that we've got to fix it mentality for a long-term issue and put that burden on our workers. As a whole of APS, we need to appreciate that this is a long-term issue. Frame it as that. Celebrate those small wins, those small victories that we have. And next time we get that case in again, or that next situation, we continue to think of this not as something that is short-term, immediate, that we can just fix, but rather something that is going to take time and may just involve us making sure that person knows where to go if they change their mind after we're done with our case in APS. Real quickly, some tips. Create a collaborative service plan. I've said this probably 500 times in the last hour. Work with that person, involve them. It is the essence of what it means to be person-directed, which we are called to do in the federal role on APS, is to be person-directed. Plan for those setbacks and relapses. They're going to happen. Start with minimum safety standards and build momentum. You'll see in the slide deck that I have a set of minimum safety standards that you can apply to hoarding that comes from Dr. Carmen Moran from the Hunter College School of Social Work. Focus on these things because these things can help dictate what the priorities are for APS, as well as how long we need to keep that case open. If someone's meeting their minimum safety standards, it may not be ideal, but we may be able to close that case. If they're not, It could be a very different situation. It also gives, for the supervisors, it gives you a place to start when you're doing supervision, when you're staffing that case. Did they have that working toilet and sink? Was there excessive accumulation? Going through these so that you can have a sense of what that situation is like that your worker is addressing. Lastly, engage in that multidisciplinary approach early and often. And very, very importantly, and I don't like alls in APS or 100% in APS, but this is one that's almost close to 100%. When you offer that service or care plan to someone who is experiencing hoarding, a referral for cognitive behavioral therapy, a referral for a mental health professional skilled in hoarding should almost always be something that is offered to them as an option. It may be something that they decline, it may be something that they don't want. That's fine. But we know that the most significant change that happens, again, over the long term, is from people who are involved with a therapist, mental health professional, skilled in hoarding, also, of course, trauma informed, but that uses a cognitive behavioral therapy technique. I'm going to end with this and then I'm going to turn it back over to Leslie. Thank you, thank you, thank you. I know we went through a lot very quickly. If you have questions, as Leslie said, please contact the TARC. They can contact me, and I'm happy to share any resources or information that I have. And lastly, I'm sure Leslie's going to say this as well, but thank you, thank you, thank you for what you do. It's one thing to talk about it on a webinar for a few minutes. All of you live this every day. You encounter these situations, you experience these situations. And I know from having hung out with APS now for, I think, 25 years, the impact that you make, those small things that you do, even if it is just helping that person clean up enough information or enough clutter so that they can take a picture with their granddaughter, or the more significant things that you do to prevent fall risk, to prevent fire in these situations. You absolutely make a difference. So thank you, and thank you for listening for the last few minutes. And Leslie, I will turn it back over to you.
Well, I want to thank you as well, Chris, and I can't say it any better than you already have. So with that, I am going to wish you all a good day, and remember to please reach out to us if you need any assistance or if you have any questions regarding today's presentation. Thank you all for your time and attention.